Vestibular Disorders and Evaluation of the Pediatric Patient by Maureen Valente and Devin L. McCaslin, presented by Amber Hicks. Why should we do vestibular assessment on children? Determining the integrity of the vestibular system can help physicians to diagnose and treat the impairment efficiently and accurately. In children with other serious health issues, vestibular assessment can identify patients whose dizziness and vertigo stems from a significant neurological impairment. Neurological impairment can include things like brain tumors. Vertigo in children. Episodic vertigo is rarely reported in children. However, when experienced, it may indicate the presence of vestibular dysfunction. Vertigo in children can manifest in many forms. For example, a child with acute vestibular impairment may present with many symptoms similar to adults. For example, vomiting, nystagmus, hearing loss, and ataxia. Children, like adults that have vestibular disorders, also may present with a progressive or chronic loss of vestibular function that affects the development of postural control. Treatment availability. Few clinics are dedicated to evaluating and treating pediatrics. Why? Children are difficult to test. Despite the incidences of vertigo in children, few clinics are dedicated to evaluating and treating the pediatric population. The primary explanation for this is that it is difficult to test children. There is not as much information clinically on children as adults. Vestibular symptoms in children are often dismissed by professionals, and there has not been much adaptation for testing in children. Common causes of dizziness. The most accurate literature indicates that the most common disorders reported to cause dizziness in children are otitis media, migraine headache, benign proximal vertigo of childhood, also known as BPVC, trauma, and vestibular neuritis. Migraine-associated vertigo. The most common diagnosis in children with vertigo and dizziness is migraine headache, although the temporal relationship has been reported to be variable. The migraine may precede, follow, or occur simultaneously with the dizziness, vertigo, often with accompanying symptoms like nausea. The features of the migraine differ from adults. In childhood, migraines often are localized to the frontal region, last less than 2 hours, and may not manifest as the typical throbbing pain described by adults. Approximately 20% of children with migraines have associated dizziness. Benign proximal vertigo of childhood. The primary symptoms of BPVC include episodic attacks of vertigo lasting from seconds to minutes, resulting in the child being unable to stand without support. Additional symptoms include nystagmus, tinnitus, pallor, diaphoresis, and vomiting. BPVC is a pediatric migraine equivalent. For example, a migraine that manifests itself in a form other than head pain, recognized by the International Headache Society classification system. During BPVC attacks, there is no loss of consciousness, and complete recovery follows an attack. A child who is capable will describe the sensation of spinning. The age of onset of BPVC has been reported to occur typically before 4 years of age. Trauma. According to the U.S. Centers for Disease Control and Prevention, head traumas in young children are common. Children suffering from trauma-induced head injuries present with headaches, cognitive impairment, changes in personality, and sleep disturbances. Dizziness and vertigo is also a common diagnosis for a significant portion of children presenting with trauma. In cases of a fracture or concussion in which the labyrinth or vestibular nerve is affected, children can experience severe vertigo with nystagmus and nausea, indicating unilateral impairment in the peripheral vestibular system, i.e. the end organ or vestibular nerve. Penetrating head injuries have been reported to cause vertigo secondary to a fistula. As an adult, pediatric benign paroxysmal positional vertigo, also known as BPPV, is secondary to head trauma, can also occur. Vestibular neuritis, also known as the inflammation of the nerve, in adults presents a sudden onset of rotary vertigo and vomiting lasting for several days to weeks. In children, symptoms present in a similar manner. The causative mechanism of vestibular neuritis continues to be controversial. The prevailing theory is that vestibular neuritis is viral in origin. Others, however, have set forth the ischemic events, as well as bacterial and other types of infections could also produce similar symptoms. Otitis media. Different theories have been proposed as to how middle ear pathologies can affect the vestibular labyrinth. One theory states that toxins present in middle ear fluid enter the inner ear fluid and cause serious labyrinthitis. Other researchers have proposed that pressure changes in the middle ear cause displacements of the round and oval windows, leading to secondary movement of labyrinthine fluid. Many published research studies have focused on how balance is affected by otitis media with effusion, although the etiology continues to be unclear. Team assessment. As with diagnosing many things in audiology, team assessment is critical. Determining the cause of a vestibular disorder in a young patient requires a thorough team assessment with pediatric-specific adaptations. Case history and physical exam. The case history is an important diagnostic tool for a child demonstrating a vestibular disorder. Normal observations may include measuring spontaneous gaze nystagmus, ensuring conjugate eye movement, and ocular motor testing, such as smooth pursuit and staccato. The clinician may check for head-shaped nystagmus. The clinician should see no nystagmus if peripheral vestibular function is symmetrical. Head thrust testing also may be conducted to help determine status of the vestibular ocular reflex, also known as the VOR. The intact VOR should allow steady fixation on the target. Although benign positional vertigo, also known as BPV, is uncommon, the clinician may easily test for it with Dix-Hallpike maneuvers. Clinicians also may perform positional testing, if tolerated by the patient, to identify nystagmus and other symptoms. Positional testing may be part of a more formal video nystagmography, or also known as a VNG battery. Finally, the clinician may perform gait and balance tests, such as the Romberg test. Formal assessment measures. The formal assessment measures may include an ENG or a VNG, computerized rotary chair testing, computerized dynamic posturography, or vestibular evoked myogenic potentials, also known as VEP. The VNG is the most common measure used in vestibular assessment of adults. It is a test battery that includes measuring spontaneous and gaze nystagmus, ocular motor testing, positional and positioning testing, and by thermocaloric irrigation. Gaze evoked nystagmus is recorded via calibrated light bar with a 20 degree to the right, left, and upward and downward. Ocular motor testing involves observance of smooth pursuit, optokinetic nystagmus, and staccatic eye movement. The light bar may adapt cartoon characters for pediatric patients. Most recently, they've been using things like trains. Positioning and positional testing are performed. In bithermal-caloric irrigation, which allows independent assessment of each peripheral vestibular system, the examiner stimulates the vestibular system with warm or cool air or water. VNG has proved to be a challenge with children younger than 6 or 7 years of developmental age. Computerized rotary chair testing. Advanced technology has brought more sophisticated measures that have facilitated testing with younger populations. The computerized rotary chair, or CRC, has successfully been performed on infants as young as 3 months. The simple harmonic acceleration subtest involves rotating the head and body at various test frequencies and time duration. Pediatric adaptations include seating the child on a parent's lap, developing a child-friendly enclosure, testing at only select frequencies, and tasking with familiar nursery rhymes. Computerized dynamic posturography, also known as CDP. This test measures functional balance and relative contributions of the visual, proprioceptive, and vestibular systems. Examiners have found it to be effective with children as young as 3 years of age. The sensory organizational test, or the SOT, places the patient on a movable platform containing sensors for measuring force of the feet in response to movement. The patient faces a visual surround that may remain stable or be sway referenced. The SOT involves 6 conditions, with the patient relying on vestibular cues in the last 2. Condition and composite scores are calculated for platform and visual surround stable, eyes open. Platform and visual surround stable, eyes closed. Platform stable and visual surround sway reference, eyes open. Platform sway reference and visual surround stable, eyes open. Platform sway reference and visual surround stable, eyes closed. And finally, platform and visual surround sway reference, eyes open. Motor control testing places the child on a platform that undergoes unexpected movement. Forward and backward movements are of varying magnitude, dependent upon patient height and weight. Pediatric adaptations include a child-friendly visual surround and diminishing numbers of trials. If attention span is limited, but they have not been studied extensively. Each test involves several trials, results of which allow the clinician to note learning or practice effects as the session progresses. The information may prove invaluable as applied toward any remediation strategies that may be recommended. Vestibular evokes myogenic potentials, often called VEMS. The VEMS is an electrophysiologic measure that provides information to the clinician regarding status of the fascia. Because VEMS is quick and objective, numerous investigators have successfully performed it with children. The test is performed by placing surface electrodes on the contracted sternocleidomastoid muscle and sternum, with ground placement on the forehead. High-intensity auditory stimuli are presented through the ear canal to elicit a VEMS tracing. Pediatric adaptations include seating the child on the parent's lap, having the child focus on cartoon characters to maintain proper position, and using selected frequencies. Research is needed related to age-differentiated normative data and finding that assists with differential diagnosis. In summary, any child with a vestibular disorder, even one that is subtle, should undergo extensive evaluation. As with hearing impairment, children receive great benefits from early identification. These benefits include the consequent early intervention that may be implemented via a team approach. Management strategies with the pediatric population are individualized and may include various types of medical treatment, surgical treatment, referral to other disciplines for vestibular rehabilitation, and investigating a monitoring program to oversee possible effects of compensation and maturation. If you'd like to read the full article, you can find it in the ASHA Leader. Maureen Valente is a PhD who teaches at Washington University in St. Louis, and Dr. McCaslin teaches at Vanderbilt University in Nashville. Thank you.